Thank you, Dr. Ambika and Dr. Urmil. That was really extensive and it was a revision for me also. I'd like to thank the AIC for inviting me here and Dr. Santosh. I like this podium. Can be seen and not only heard. So everybody has a mobile phone, right? And everybody has pens and papers, just put them away because you're never going to read the pictures you take. I assure you that. Okay? So listen, we're going to make it interactive. We're just keeping pictures. There's not too much theory because honestly, there's a YouTube video by the who's who of oculoplasty, which is not me. I have no YouTube videos, but you have really good stuff. So let's just take and see a few pictures. Someone's taking a photo of me before. Oh, okay. It's my resident. Tell me, I'll smile before, huh? They will, but I'm just saying, just let's keep it interactive and fun. And there are a lot of patient full-face photos, so genuinely requesting, just it's going to be enjoyable, okay? So let's not get too stressed about it. So the first question we ask is there proptosis? So proptosis, as we know, is defined of a difference between more than 2 millimeters. Then what is exophthalmos? Can we use it for a case of proptosis? So in the exam, if you say this patient comes with has exophthalmos, will you be picked? Maybe, because exophthalmos specifically was described by Henderson for thyroid eye disease. So try not to use it for that. So the first question then is, if there is proptosis, or is there not proptosis? So is it pseudoproptosis? That's the first thing you ask when you get a case of proptosis. So let's take both these patients. The top lady has what she thinks this eye is prominent, proptosis, and then he thinks this eye is prominent. But if you see actually in this, the eye which looks prominent, that means the ipsilateral or the same side eye has a lid retraction. And what do you think here? Why does this eye look prominent? Yeah, it's ptotic. There's browtosis. It's a giveaway. It's very simple. So ipsilateral and contralateral eyelid signs. Then what about these two? One has bilateral and one has this eye looks prominent. There's a little sign here, some ecchymosis. Yeah, correct. It's an enophthalmos, and this is actually myopia, but was been kept constantly told he has thyroid eye disease, but he didn't. He was a known myope. So basically, eyelid signs, globe positioning, and lastly, this girl here, which is facial asymmetry, very well seen, along with a lid retraction. You can see this entire side is hypertrophic compared to this side. So facial asymmetry. So first question is, proptosis is there. It's not pseudoproptosis. Second is it unilateral or bilateral? Yeah. So this is just a common laundry list kind of thing, just to remember. And at the time of the exam, you never remember this. You're in a state of panic, but it's good to know these broader things when you're answering. And then it's further divided into adult and pediatric. These are some of the most common causes. They're all there in your book. You don't need to take a picture because all of these are given in most of the books you read. This is according to age, so you can either divide it according to unilateral, which is most common, and bilateral, or according to age. And this is a very nice article which is given, which is easy to access on PubMed, and it's free, and it just talks about etiology of proptosis. So we've answered 2 questions. Let's get on to the third. So we know there's a proptosis. We say it's unilateral, okay? And then we want to know direction of displacement. So most of the times I just tell the residents that you have to know your anatomy. Whatever is there in that quadrant, it's going to push it to the opposite quadrant, and that's all you really need to know. So this first patient has a unilateral proptosis on the right side. Is it going anywhere? Not really, right? So axial. So axial proptosis, fine. Then this lady, very obvious, is getting an inferior displacement. Inferiorly, superior lesions is, what do you have on top? You have your frontal sinus, you have your lacrimal gland, you have muscles, you know. So muscles, nerves, fat, anything can come from those. But primarily, if you just rule out certain main structures, frontal sinus, mucosa, lacrimal gland. So these are some of, this is just a kind of a breakup of the, lesions that can occur. Blow-in fractures. And then this is a little subtle. If you see, there's a unilateral, what we call a telecanthus. So it's pushed laterally. So if you have a dacryocystitis, would you get this? Acute dacryocystitis. Not so much a lateral displacement, it would be a more a superiorly, because your lacrimal gland is below your medial canthal tendon. So anything that actually causes a telangiectasis is actually coming from the ethmoids. So ethmoid, sinus mucocele, tumors. So this is kind of the displacement. So we've answered question number 3. So now we say is the duration. And this sequence that I'm going in is something that Shields has described, but it's something that stayed with me through my UG and fellowship, and I really like it. So duration is catastrophic, which occurs within minutes and hours, acute, subacute, and chronic. And then, of course, the clinical course of the disease. Before we go to all that, you need to know how to measure it. It's good if you can have a Herter's exophthalmometry and you can do it. Most of you, will have people teaching you. This is something that you should know, that is displacement. Displacement does not require any fancy things. You need 2 clear plastic rulers. One goes through the center or the pupillary reflex, and the other passes through the lateral canthus, and you will know the displacement hyperglobus or hypoglobus. So you can actually say there is a proptosis with a displacement downwards of about 3 millimeters. So there's a unilateral proptosis with a downward displacement of so much, or a hypoglobus or a hyperglobus. So it simplifies it, but allows you to measure it in your exams and gives you a little brownie points. Now this is just, again, inspection, palpation, we know the drill. This is something, it's a nice chart which I really like. It's in one of the books, which is chapters, which is going to get published, which really just talks and asks questions, It basically asks if you can see how is it progressing, and these are some of the things that you really like. It comes as a laundry list. And this is something that you can actually tick mark and read. Yes, you can take a picture. Please go ahead if you want. It's going to come in a chapter. It was done by Neerav and me, and just on proptosis. And it's just something to run to, like literally like a ready reckoner, ki ye, I have to read this. Okay? So let's come now down to the basics. So we're starting with adults. Unilateral proptosis, yes, it's acute, it's painful. There's eyelid edema, there's a little bit of extraocular muscle restriction. So let's take the first patient. That's his eye. There's proptosis, eyelid edema, chemosis, little bit of congestion, but this is the CT scan. Is there anything? Looks pretty normal, right? Do you think there's something in the CT? It's not a trick question, there's nothing. So when the CT is not matching this, and there's only preseptal edema, it's a preseptal cellulitis with a chemosis, what do you think it could be? Yeah, someone said it, I think. It's just an angineurotic edema or an allergic, kind of edema. It was there was no history of any insect bite, no history of any drug, food, allergy, but literally just resolved without antibiotics. We just gave anti-inflammatories and anti-allergics and it's resolved. So don't get fooled by pictures like this. Sometimes, just movements were normal. There was a very subtle proptosis. There was this, but the orbit was clear. So like a proptosis which was so subtle that it was going into an orbital cellulitis. We didn't even have to give steroids. So that's the patient just after anti-inflammatories and anti-allergics. Now unilateral proptosis, painful, acute, and this is the CT scan. So this is a coronal and axial. So there is here a homogen dense lesion with a slight lining which is lighting up. What do you think this is? Yes, it's a subperi. So it's an orbital cellulitis primarily, which has gone into a subperiosteal abscess. So this is acute, unilateral, acute, with restriction of movements, eyelid signs, and that's her after a course of antibiotics. One notice sometimes in these patients, you do need to drain it, but in children, we may not need to drain it if they're under 9 years of age because they usually self-resolve with IV antibiotics. You may need to add steroids 48 to 72 hours later after an antibiotic cover. So second one is, again, similar picture, full ptosis, restriction of movements, but can you see no ecchymosis? So I'll give you a clue. That's a MRI, filled, the sinuses are filled. Patient had COVID. Yeah, my residents have done a PhD on mucormycosis. So as of all of you, so yes, so we have to put this in, mucormycosis. Unfortunately, This was an immunocompromised young adult, so developed mucormycosis, and the management, of course, remains whether you have to give systemic antifungals with or without orbital debridement, and if required, exenteration, but we have also started giving transorbital amphotericin B. Okay, unilateral proptosis, subacute, okay, had a little bit of pain, discomfort, ignored it, and then had a sudden bit of proptosis with diplopia, so, and restriction of movements. What would you think in a young adult like this? There's no like much redness. So I'll just give you the CT scan. Well, inferior rectus, well-defined lesion which are hyperdense. Yes, superb. This is cysticercosis. So more common in, of course, LPS and SR complex, in which you'll actually get a ptosis. So he has a very subtle ptosis, but that's also because of the restriction. The inferior rectus is so tight, it's pulling it down. So you basically give antihelminthics and they resolve. Now let's go from acute to subacute to chronic. So you have painless proptosis with or without restriction of movements, no vision loss. So what kind of proptosis do you think this has, right and left eye? Axial? Axial. So basically intraconal lesions we are looking at. So this is a gentleman who had a nice, well-defined intraconal lesion with calcification. Yeah. Yes. So it was a cavernous hemangioma. But yes, you have other differentials also. But this was a cavernous hemangioma. So the other lady who had a schwannoma. So the only difference in this was there was a little bit of calcification. This is more globular. This is spindle-shaped. I think most of you know this. So intraconal lesion, subacute to chronic. But now unilateral proptosis with an inferior displacement. Okay, and this was the CT scan. I could see it through the superomedial fornix. Anything that's superomedial, superolateral, right here or here, even in an adult, what would you think of? Sorry? Dermoid. There's not much connection with the sinus. So this is a dermoid, very classical, well-defined. So in an adult also you can get, or any of the cysts, epidermoid cysts, dermoid cysts, retention cysts. So we did a transconjunctival incision and got it removed. So transcaruncular actually. Now let's come to the chronic ones. Now all these patients have proptosis unilateral, which is chronic, so in months. So there is some amount of pain, there is some amount of eyelid signs with EOM restriction. So this is actually the differential, which is the commonest differential. There are many more. So coming to this lady, if you notice, she had a little bit of eyelid edema. She has a little fullness on the row eyelid, unilateral proptosis. While this gentleman has upper lid fullness in both the eyes with left-sided proptosis, and this is her scan where there was a lesion in the inferior part. And this is his scan with the orbital lobe of the lacrimal gland. So anything that proptosis, which is chronic, which has some amount of dull, aching, periocular, periorbital pain, you start thinking chronic ailments such as autoimmune diseases, IgG4, thyroid eye diseases. This is basically your differential, where they will come with this classic looking puffy appearance, and they are usually unilateral. So now this is a unilateral ptosis with an eyelid sign. The previous people had ptosis. This one doesn't have ptosis. She has eyelid retraction and lid lag. So, yes, thyroid eye disease, and that's post-steroid. Again, similarly here, thyroid eye disease. Now, unilateral proptosis, these are a little unusual, but it's important to know. Again, inferiorly displaced lesions, as we discussed earlier. And, of course, lateral displacement with ethmoid lesions. Now, bilateral ptosis in an adult, which is acute. Now, you're shifting from unilateral to bilateral acute, painful with loss of vision in both these eyes. So, similar pictures. Let's see this CT scan. Look at her muscles. Thyroid eye disease, yes, with dysthyroid optic neuropathy. And look at this one. CCF, so dilated superior ophthalmic vein. So this is bilateral acute. Usually, if you get a bilateral acute, it's pretty straightforward and common. And you will also get those typical corkscrew vessels, and you will actually hear a wonderful bruit if you can, especially if you've seen a CCF. And you don't need to do a CT scan. We usually just catch it with an ultrasonography. Now, bilateral proptosis, acute or subacute to chronic is what we are going. So subacute to chronic, upper lid edema, little redness in the superior fornix, lacrimal glands enlarged. Upper lid edema with bilateral proptosis, lid retraction. No lid retraction here. What do you think this could be and this could be? So we've gone through the other common ones, autoimmune diseases, IgG4, thyroid eye disease. So sometimes some patients still don't, they come to you at this stage. So for thyroid eye disease, where they've progressed already, but they may not have loss of vision. So this is a chronic case of thyroid eye disease, and this is a case of lymphoma. Okay, so bilateral lymphoma actually, so systemic lymphoma with bilateral involvement. Usually it can be asymmetric, most often where patient will present with either a lacrimal gland involvement and you biopsy and you realize it's involving. Now let's take a pause and let's just last 2 minutes. I'm going to go over 1 minute more of my time. Now let's come to children. So children, the most thing is there are a lot of things for chronic, but I'm just going to highlight a few acute ones that we need to know. So acute proptosis, okay, with loss of vision. Both are the same diagnosis. One came without much signs but vision loss, and one came with sudden onset proptosis with redness, lymphangioma. So it will cause a sudden onset bleed. You sometimes need to go in and aspirate it and give a pressure patch and then plan, or even in the same sitting, plan a sclerosing therapy, which you have sclerosing agents such as bleomycin. So this is in children. Of course, orbital cellulitis is there, which I'm not getting into, but every case is not an orbital cellulitis. You can get a sudden onset in an infant, which could be an undiagnosed lymphangioma. So this is actually a 5-year-old boy who came with a sudden onset proptosis. You can see a scar here has been, he made an incision to do a drainage without imaging, thinking it's a cellulitis, got nothing. So this is a scan. So it's a homogeneous dense mass. So sudden onset proptosis, orbital cellulitis, lymphangioma with bleed, third onset in an infant or a child, what would you think of? Yes, it is a rhabdomyosarcoma. And we could excises in toto. It was an adnexal plus orbital one. So that's your next one. Finally, this is now going a little more into chronic unilateral proptosis in a 9-month-old girl, increases on crying, worsening, capillary hemangioma. So this is a complex, superficial plus deep, and the management, of course, you know, is now propanol, which works even for orbital. If there is any ptosis which is covering the eyelid and you want to improve the eyelid and not cause amblyopia, then you can do intralesional steroids with propanol. Okay. Unilateral proptosis acute, coming like this with an opacified eye, looking like orbital cellulitis, but this is the CT scan. Retinoblastoma with possible extraocular extension with sterile orbital cellulitis. So this is actually a thysical eye which is shrunken just after chemotherapy. So this is, as we all know, and even Dr. Hunawar keeps harping that in a child who comes within the first 3 years with a proptosis should be done. And finally, this slide is of a unilateral proptosis of a child. He's about 3.5. He came with a sudden onset swelling. Can you see a little bruises here and there? So again, this is leukemia. So the main thing that you need to do is a complete blood count and a peripheral blood smear. The others are dermoids, which you already commonly know, which I'm not getting into. And of course, optic nerve gliomas, okay, which are chronic lesions. So to just summarize, basically just go through the certain questions that we went 1, 2, 3, 4, 5, know your anatomy, and then based on the age, you don't need to know, nobody expects you to know the entire spectrum, but just know the first 2 to 3 top diagnoses. Imaging is something that goes hands in hand with us and we need to know it. And finally, just like to invite all of you to our midterm conference in Aurangabad, which is on 3rd July. It's a 1-day conference only on eyelids. Thank you.